Always my pleasure and honor. Super happy to be here today. I'm having some tech difficulties, so please unmute and shout out if there are any troubles. Really important topic today, and a little intimidating to do a mini didactic on such a major problem, but here we go. No disclosures in case already shared who I am. So my objectives here are to define and highlight signs of elder abuse, neglect, and exploitation, discuss why it's so hard to report older adult mistreatment, and review the importance of interprofessional teams. And we'll talk specifically, and I have a special guest, Scott Rosewood from the Elder Abuse MDT in King County to chime in at the end. I'll also be talking a little bit about APS, because this is a really big, hard, and broad topic and comes up a lot in primary care. I think oftentimes what I'd like to present to you here is not a new framework, but might be a little more of an expanded framework from which you think about elder mistreatment. And you can tell that the language is an evolving landscape, right? We are moving away from abuse just because there's so much stigma and there's such a range, and more towards mistreatment. But I may be using them a bit interchangeably. And the way I want you to think about the big broad umbrella topic of elder mistreatment is not just abuse, which can be physical, sexual, and emotional. And that's the area I think we think about often when we think about elder abuse, but also exploitation and neglect. So why should you care? I think the most important reason that you should care as a member of a primary care team is that that elder mistreatment is common and very, very underreported. So common up to 1 in 5 older adults, and underreported up to 95% of cases are not reported to people. And so it's a huge area of opportunity, and oftentimes it is actually happening right in front of us in, for instance, in an exam room or in a home-based visit, when we have family members there who, for many multiple complex reasons, may be the perpetrator of mistreatment. In the very specialized population, I think, that we think about in geriatrics are people living with dementia. Very common, almost 1 in 2 in some cases have been a victim of some form of mistreatment. And that even minor cases of mistreatment can lead to major bad outcomes, including premature deaths, but more importantly, quality of life issues. So we're going to go through all the different types of elder mistreatment, and I'm going to kind of have you chime in the chat before I share with you some things I want you to look for in the exam room. So this will be our test slide here. I'm going to define physical abuse. So that's intentional use of physical force by another, regardless of resultant injury, pain, disability, or impairment. And I want you to type in the chat, what are you looking for when you're in an encounter in the clinic, in the home, in the nursing home, or in the hospital that might be a red flag or something for you to consider physical abuse? What are you looking for?
All right, I'm going to read these out loud. We have fear, intimidation, not talking. We also have bruises, fractures that don't match the narrative.
Perfect. So I'm not going to read all these out loud, but these are some things that you're going to look for. And on the next slide, I'm going to show a little bit about bruising patterns and research and what we know about this in terms of just increasing our level of knowledge when it comes to physical abuse. So this is one resource in general that we have for learning more about elder abuse, and that's the National Center on Elder Abuse, and there'll be a link at the end. But this is this concept of, okay, we have some research, probably not enough in elder abuse, but how do we translate that into practice? And so this is just one example of what we're looking for when it comes to bruising. And so the picture on the left are accidental injuries, and the picture on the right are reports of those who have been victims of physical abuse as older adults. And you can see the patterns are different. And, you know, specifically you're looking at the face, you're looking at flexor injuries in the arms, and you're looking at that lower back area. So those are it's just an example of what to be looking out for when we're seeing bruises. When we move on to sexual abuse, happens. It happens in all locations that we need to have a high index of suspicion. It's defined as intentional sexual contact by another to a non-consenting other. It can include rape, human trafficking, indecent exposure, photography. And these are some things that we need to be looking out for. This is complex because on the other hand, we also know that older adults have sexual lives and interests, and we need to be balancing some of the challenge of signs of abuse and signs of autonomy, which you'll hear come up throughout this talk today, is sort of this autonomy versus safety when we think about elder mistreatment. Emotional abuse. So this comes up a lot, and there's a varied range of emotional abuse. So intentional verbal or nonverbal actions that inflict mental or psychological anguish, pain, distress, or suffering, berating, harassing, intimidating, threatening action or inaction, infantilizing, isolating, manipulating, or cursing. So those are sort of kind of what is it, right? What are we going to look out for in the individual that we're caring for? Type that into the chat. So we're looking out for behavior changes. Is this person personality changing? Do you want to go ahead, Kate?
Oh yeah, Elise put in the chat, lack of eye contact, relative silence, especially in the company of the caregiver.
Yes, exactly. And so specifically behavior changes, and this is where, as a primary care team who know individuals, you're looking out for changes in their behavior. Were they very social and now have become isolated? Did they come in and have a pretty good outlook and now feel very negative or poor in terms of self-esteem? Has their grooming changed? And that comes up across multiple areas of this treatment. Okay, so we've moved through this subset of mistreatment, which is physical, sexual, and emotional abuse. Let's work now to financial exploitation. So financial exploitation is the intentional, improper, or illegal use by another's money, assets, property, resources, or belongings. What are you going to look for? How are you going to know? How are you going to raise your index of suspicion for elder financial exploitation? And as you type this in the chart, I'm going to share that I am really honored to be part of a AGS 2023 proposal that is moving through the ranks on this very topic. And the cool thing about it is that it's going to include a neuropsychologist who does brain imaging research on brain imaging findings in early, even pre-dementia states that put people that are linked to risk for financial exploitation and serial scamming. This is a really important issue, and I'm curious what you would be looking for in terms of financial exploitation.
Stress or worry when discussing finances is one answer from Tiffany.
Excellent. So, like a newly mishandled finances, like somebody gets their, somebody's doing just fine, and all of a sudden they have obvious newly mishandled financing. I see this all of the time, which is sort of a lack of money being put towards care, right? So stingy decisions, including like caregiving, and this is a very complicated issue, but something to look out for. Some threats designed to coerce the older adult in terms of making decisions. The new best friend, right? That's part of the older adult's life. These are complex things that we're looking for. And there are some tools that you can, this is linked in the end, that you can look at, but this concept of like who is at risk for elder financial exploitation and what can we do about it is very similar to thinking about advanced care planning. It's talking about it early, making connections when appropriate with family members to be part of observing how the money is being spent, giving people independence and autonomy when appropriate as well. And so a complicated but important issue. So moving on to neglect, which is extremely common and extremely complex. The definition of neglect is not fulfilling in part or whole the care obligations of another one's self that result in harm or risk of harm. And in part, not fulfilling those is called neglect. In whole, if you completely abandon somebody, it's called abandonment. And this is separate from self-neglect, which we'll talk about on the next slide. And it's one of the very complicated issues that I can't get into in this mini didactic is sort of how do you establish that somebody even has the obligation? Is the adult child of the older adult obliged to provide care for them? The short answer from a legal perspective is no, but there are certain circumstances where that obligation is important to discern. Self-neglect is this general term used to describe a vulnerable adult living in a way that puts his or her health, safety, or well-being at risk. And I'll let you guys look at what to look for here. And it's very, very important that we understand how to define a vulnerable older adult. And that's going to come up in a slide in just a minute. So why is it so hard for victims to report older adult mistreatment? Like, why doesn't everybody just sort of report it when they're not being mistreated, when they're being mistreated, and then we can take care of it? Why is it so hard? That in. I'm just going to keep going just for the sake of time, but thank you for thinking about this. You know, sometimes it's not reported because somebody's completely dependent on the perpetrator and they don't want to get them in trouble. Sometimes they feel shame about reporting, and sometimes they love the person who is mistreating them. They fear retaliation, they fear their loss of independence. Sometimes they don't know they're being reported, especially in the setting of dementia or cognitive impairment. And so let's think about us as the clinician, as the team. Why is it so hard for us to report it? Well, we don't want to alienate our patient. We don't want to experience the retaliation. We are not certain about what's going to happen when we report it. And hopefully I'll get in the next couple slides a little bit of understanding about that piece. And then sometimes we just say, I don't know what's going on, but I really think that that person is doing the best job they can caregiving right now. And so what is our role, right? What is the role of our team? We need to suspect when we see all those things that came up in the colored boxes before. We need to do a really careful clinical assessment. We need to document the findings. We need to ensure immediate safety. And sometimes that means calling the police because APS is not an emergency situation. And then we need to be able to access APS when appropriate and know about some other teams in our community, which I'll talk about. Because even though some presentations are really dramatic, and we have all heard about those, and I certainly have as part of the elder abuse multidisciplinary team, but most are nuanced and subtle, and we need to be looking out for them. So what about APS? APS reports, investigates, okay? They investigate reports of abuse, abandonment, neglect, exploitation, and self-neglect. They work on the concept of investigating these only if somebody is considered vulnerable, and we'll talk about that on the next slide. There is always a priority of autonomy, which means you may be worried and there may not be a whole lot in terms of like the investigation that can be done, but really importantly is that they offer services, and we need to keep that in mind. So this is sort of the legal definition of a vulnerable older adult, and so it's 60 or older with functional, physical, or mental inability to care for self, pretty broad, or 18 and older with these other circumstances, including anyone living in a facility. So it's really important to know that you should have a low index of suspicion and refer to APS. And this is a really important thing. If you take nothing away, when you report to APS, usually online, but also by telephone, it's very easy to find that online, Googling, you need to be thinking about what to communicate to them. And what you want to communicate them is whether you think they have any cognitive impairment or a diagnosis of dementia. If it's a dementia, you want to try to stage it and you want to say what it's due to, because the specificity is important. Is this mild dementia, or is this early dementia, or is this later stage dementia? Does their cognitive impairment, if they have it, rise to the lack of capacity in the situation that you're evaluating? And are they at risk of harm? I could go into this in more detail, but I'm going to keep moving because I want Scott to unmute and to introduce himself and tell us a little bit about the team that he invited me to be on, that I have the pleasure of being on. And then I also have a slide, Scott, about the form here. So I will hand it over to you.
Yeah, I will point out that I think I was invited to be on the MDT after you, Carrie. So, but I appreciate that. Hi, everybody. I'm the coordinator for the King County Elder Abuse Multidisciplinary Team. I'm going to be moving very quickly because I know time is short. Carrie kindly put up on this slide our primary partners. And it's worth noting that, you know, we are housed within the King County Prosecuting Attorney's Office, but our program really does focus on the alleged victim and what is best for that alleged victim. We're not interested in just, you know, prosecuting perpetrators or taking away rights. As Carrie pointed out with APS, we're really interested in protecting and making sure that the vulnerable adult is safe and able to live their best life possible with as much independence as possible, not prosecutions or other things. And we also invite in other professionals and service providers as needed based on cases. And then real quickly, I will cover in the next slide our referral form, just to lay out what the criteria are. Mostly, I will point out that we are funded by the Department of Community and Human Services. And so our definition of cases that we are able to take for older adults is slightly different than the legal definition for ABS or ADS. So we will take cases for anybody 55 years or older. The other big piece of that is they either have to be in King County or the abuse has to have occurred in King County. There has to be a King County nexus. And then ideally, there is some complicating factors, whether that is coordinating across lots of agencies that are responding to that elder abuse, or whether it is just that there are serious financial analysis issues or medical issues that are hard to understand or navigate. We do better with things that are like financial exploitation and physical abuse and sexual abuse and stuff like that. It is hard for us, just like it's hard for anybody, to deal with the severe self-neglect cases, but we will consider anything. And even if something is outside of that 55 years or older, we will consider it on a case-by-case basis. So the one real takeaway that I would offer up is that if you have any questions about a case, whether it's, does this rise to elder abuse? Is this something I should report? You know, you're struggling about how to move forward, I would invite you to please reach out to me. I may not be able to answer your questions, but I can put you in touch with whether it's ADS or the Prosecuting Attorney's Office or APS, whoever is appropriate to answer those questions. So we'd always rather you reach out. You're not wasting my time. We wanna be here to help.
Thank you so much.
Thank you, Scott. So just a statement, and then I'm done, I promise, Kate. Older adult mistreatment is common and preventable, and we, as healthcare providers and healthcare teams, really play a key role in identifying mistreatment. And so thank you for the opportunity. Here are some references, which Amy's going to send out in the future. But thank you for your attention, and happy to take a couple questions before we launch into the case.
Thank you so much for the overview of a really big topic, Carrie.